determine how much, of course, of number of tablets should this patient get, because remember, this is their strength composition. So you want to determine how many tablets should this patient take, okay, so it should be equivalent to the normal dosage that the patient would need. You can use either of the drugs. So I like to use the core drugs. Core drugs in this category is Isoniazid and Rifampicin. These are core drugs in TB management. So in the first line TB treatment, the two drugs are the core drugs, are very important drugs. Now, what you can do basically, you multiply. So we can get Isoniazid, which of course I said in adults we're dosing at 55 milligrams. So you just write 5 milligrams per kg per day, multiplied by the weight of the patient, which of course in this case is 60 kgs, and then kgs of course will cancel. These guys will cancel each other. They multiply, of course, your 5 times this is what you call, give me 300 milligrams. So this gives us what you call, for this patient who is weighing 60 kgs, requires 300 milligrams of Isoniazid for their TB treatment. So in this case, if I'm next step to determine number of tablets, I will look at the strength of Isoniazid, which I'm using here in the fixed dose combination. And Isoniazid strength, of course, comes in at 75. So I'll divide the patient dose, which is 300 milligrams, which I've obtained by multiplying the 5 milligrams per kg body weight of Isoniazid as an adult dose times the weight of the patient. So divide by the strength composition. In this case, 75 milligram, of course, which is for Isoniazid. And when you divide milligram, of course, will cancel, remaining with the plain ratio aspect. So you're gonna divide 300 divide by 75, you get 4. The answer is 4. So this means 4 tablets. So if a patient is 60 kgs, they will get 4 tablets of 4FDC. So this is how we arrive at this aspect. So don't put it in your mind, memorize the table. You can simply evaluate based on knowing the dose of the patient, of each individual drug. If it's Rifampicin, it's 10 milligrams per kg body weight. If it's Isoniazid, 5 milligrams per kg body weight, like that. So you can determine the number of tablets by, if you already know what the dose the patient. And remember that I've put this strength composition of fixed dose combination because this is what is common in Zambia, because we're using this strength composition of INH 75 milligrams and other thing like that. So that's how you determine this. So if I'm asking students, that's why when my students, when they're telling me the dose, then they are quoting the strength to be the dose of the patient. I said, no, that's not the dose of the drug. This is simply the strength composition. The dose of the drug must be calculated by simply multiplying. It's a weight-based dosing for regarding to TB medication themselves. I think that's understood. Most people that worked with me, they understand how I emphasize this important point. Oh my God, this is amazing. Now, this is how basically the TB drugs are dosed. Now, let's look at now the individual medication now to highlight further, to explain a few things. What are the things that, of course, you have to look into for this medication? I won't talk about the mechanism of action of the drugs here for now. No, that will come in as in pharmacology. This is just simply approach therapy for the medication. So as a pharmacist, I want to highlight that the two drugs here, Isoniazid and Rifampicin, require an empty stomach. And an empty stomach, we're not talking about empty stomach whereby there are no intestines. We're talking about a stomach, of course, that is no food, of course. And this, of course, is defined as either within, of course, below 30 minutes, okay? So meaning that the normal gastric emptying time basically is around 20 minutes, 25 minutes, all right? So meaning that if a person take medication on right now without any food in the stomach, this medication, of course, will be leaving the stomach within the next 20 minutes. Will be out of the stomach. So we tell the patient that they may eat 30 minutes after taking the drugs. They take the drugs first, because if they take after eating, the acid will come and destroy. These drugs are what you call not acid stable, so they'll be destroyed, and this can result to treatment failure. Studies have shown that 90% of treatment failure from the TB medication are due to what we call low drug level concentration. And one of the major cause of low drug concentration is about taking the medication wrongly, how the patient they take this medication. And that's why as pharmacists now, you come in now by telling the patient improper instructions. And so one of the things that I highlight is that you take the drugs, they may take the drugs first, and they may eat 30 minutes to 1 hour after they have already taken the drugs. Or if they've already eaten, basically we recommend 2 to 3 hours. So the patient may eat 2 hours after, so they may take the drugs 2 hours after if they've already eaten. So that's another way you can talk about this aspect, because this is very important, as I already highlighted. Very important to understand. All right, so we know about this medication. So what about things that you have to know about these drugs? Number one, let's talk about Isoniazid. Isoniazid, oh my God, the major side effect that you have to look out as a pharmacist when you're taking these patients, number one is that Isoniazid causes what we call peripheral neuropathy. Isoniazid is a potent enzyme inhibitor. It inhibits, of course, majority of the CYP isoenzymes, and it inhibits, of course, an important enzyme which is important, of course, in the biosynthesis of vitamin B6. All right, so from simply an alcohol state to an aldehyde, which is the active form of vitamin B6, which is important in the neurotransmitter synthesis and the normal function of the nerves. So if you are giving Isoniazid, it will inhibit that enzyme, which is known as the pyridoxal phosphokinase, and as a result, patients most likely present what we call with the peripheral neuropathy. Of course, there are two sides of peripheral neuropathy. Okay, there's what we call peripheral neuropathy with the positive symptoms and that of with the negative symptoms. So with the positive symptoms, we're referring to what we call tingling sensation or prick type of pain. All right, so more like electricity shock. People like, I'm feeling like electric shock in my legs, so you are in the lower extremities and the legs most of the times. Or that is what we call the positive, which is that one is not, of course, the initial phase of the peripheral neuropathy. The latter phase, which is the worst, I mean, this is where now progression to severe stage is what we call, where there's what we call negative symptoms like numbness, paralysis. These are end stage of peripheral neuropathy. Okay, so to counteract that side effect of this one, that's why it's given with what we call with the active form already of a vitamin B. A vitamin B drug, which is known as the pyridoxine, which is given together with Isoniazid. So this dose can be given in a varied dose, 25 to 50 milligrams once daily. Let me highlight that there are risk factors. Now, this is what you know. There are patients who are at risk factors of developing peripheral neuropathy due to Isoniazid. Number one, of course, what we call is those that are co-infected with HIV. Those at risk of having one. This second, patient, of course, with poorly controlled diabetes, just general diabetes, especially those that are poorly controlled. This puts them at risk of having peripheral neuropathy. Other ones, of course, what we call malnutrition patients. Those people, of course, with poor nutrition status, they are at risk of having peripheral neuropathy. And the high dose INH as well is another risk factor of having patients with the peripheral neuropathy. And apart from that, also those that are what we call chronic liver dysfunction, maybe hepatitis or other liver damage, or alcoholics. Another alcoholics, of course, also are at important risk, because alcohol is known to deplete almost all vitamin B themselves. So that's another risk factor for having this side effect. So meaning, that's why I'm saying that most of our patients, we give them a normal dose of 50 milligrams once daily. For the basic ratio, of course, can vary. Usually for every 300 milligrams of Isoniazid, you're supposed to give 50 milligrams of B6 as the ratio that is recommended. But of course, remember, high risk patients, don't even forget giving them B6. Very important to understand that. The other side effects of Isoniazid is simply also, it's a common cause of fulminant hepatitis. The most common cause of fulminant hepatitis is Isoniazid. Okay, but the one which is the most hepatotoxic drug is Pyrazinamide. Very important to understand that point. Okay, so INH, of course, can also cause hepatitis. That's the other common side effects. The other thing apart from that is also that Isoniazid can cause psychosis. Mechanism, of course, simply through the same path of B6 in the GABAergic aspects, thereby having an opposed sympathetic, an opposed what you call excitatory activity in the brain. So seizures and psychosis can be also occur. These are rare side effects of Isoniazid. Alright, so we know what Isoniazid can do. Okay, let's go. Next part is Rifampicin. What is special about Rifampicin? Number one is simply, this is the potent enzyme inducer. It induces, it's a broad spectrum inducer. Rifampicin induces almost all all isoenzymes. Of course, the CYP cytochrome, of course, 450 enzyme system, which includes 3A4, we've got which metabolizes about what 60% of clinically used drugs. We've got the 2D6 is also affected, which metabolize about 30% of medication drugs that are used clinically. We've got the 2C19, 2C6, and all that, and 2C9, 2C19. These are isoenzymes that are affected by rifampicin. So it's an enzyme inducer, meaning that it supercharges the enzymes, thereby every other drugs which are substrate to this enzyme that are induced to be affected, their plasma concentration will be reduced significantly. That's why the drugs like the integrase inhibitors, the proteases that are used in HIV, we either double the dose or remove them, because rifampicin is able to reduce the concentration of such medication, which may even lead to treatment failure in patients who are on these medications. Very important. So the important part highlighted is what called the PPIs, that are the PIs. Like in this case, we're talking about the protease inhibitors and atazanava, darunava, and ropinava. So for darunava, ropinava, and darunava and atazanava, these ones, of course, you have to avoid. But for ropinava, you can double the dose. You double the dose or super boost it. When you say super boosting the drug, is basically why you use 1-to-1 ratio. So mean that atazanava, sorry, if it's ropinava, the dose, of course, usually is 400 milligrams BD for an adult. So and usually 50 milligrams, of course, basically of either what you call ritonava. So in this case, super boosting is where you simply you super boost it by simply giving 400 milligrams and also 400 milligrams of, so ritonava 400, ropinava 400. This is called super boosting. That's another way. In this case, you won't double the dose, but just simply super boosting the drug. So thereby that is also what you can do with regard to this dose adjustment in these patients. Rifampicin, of course, is means that it affects a majority of the drugs. It even affects also oral contraceptives. If you are taking these drugs for prevention of pregnancy, because then you have been found to have TB, you have to use other alternative contraceptive measures because you get pregnant, because rifampicin is able to reduce your plasma concentration of these medications. So I'm using these terms, guys, because I'm talking to medical people more, and pharmacists especially, and other, of course, generally nurses, doctors, medical students, students all over across. That's what I'm talking much. My emphasis. That's my approach of my lectures. So that's why I use these terms. Basically, it's not for layman's people to say to understand what I'm talking about. So it's you guys that dispense drugs to talk to those patients. These highlights. Okay, so I think about rifampicin. Now, this drug, of course, is done goes what you call body fluid discoloration. It changes the color of body fluids. So you're usually to orange or to orange red. So these guys, of course, somebody will come to you like, hey man, how come I've been taking this medication, now my urine color has changed? Is it that I'm bleeding or what? So it can change the color fluids, the body fluids. That's rifampicin. Very important point to understand. Patient must be counseled that if you see change in urine color, don't be afraid. It's not that you are bleeding, but rather it's one of the side effects that of this is excipient side. This is simply excipient problem. Okay, that you have to assure the patient that there's nothing wrong with them. It's just with the drug color itself for rifampicin. The other thing about rifampicin, guys, is also among the three drugs that are toxic. It's a list, of course, about a toxic drug to the so it is, of course, list one as well, one of the each side effect as well. All right, the other thing about rifampicin, guys, that is very important also to note is that this is the drug that got fast rising effect. So very important drug that it can rise within a week, even days. Studies have shown that can make somebody, of course, can convert sputum from positive to negative within even days of use of rifampicin. So first, that's why it's a very important drug to people who are sputum positive TB, so that we can as quickly as possible sterilize their sputum so that they become less, or rather not infectious, and can easily go to the public, of course, and that's the essence behind this medication itself. Awesome. All right. Another thing about this drug here is the drug that is got a very broad, among the drugs that are here, it's one of the most broad drugs. It's a very broad drug. It is also used to treat other infections like bacterial meningitis, for example, where there's Listeria what you call, in the case of where there's Neisseria meningitis, as well as also Haemophilus influenza type B. So rifampicin is quite broad spectrum. It covers for gram-positive as well, and also a bit of gram-negative bacillus, a few organisms, okay, like E. coli. Okay, so it covers a number of this guy is broad. And again, regarding to the family of mycobacterium, which I earlier highlighted, this drug is very broad. It also covers mycobacterium, of course, other than tuberculosis and mods TB like abscessus, MAC. Is still one of the core regime, part of the drug used for those kind of TB or atypical TB pathogens. Atypical means, of course, that's why it's even where the way it works, of course, works on the DNA level. So it's very good for that kind of organisms. Very important drug here. Very classic medication here. Awesome. It can, of course, cause it's among the TB that I hear drug here again. The other thing to watch out here as a side effect for rifampicin is the most common cause of acute kidney injury, AKIs. Acute kidney injury through immune reaction or immunocomplex is done by rifampin. Ethambutol is not major cause of AKIs, but rifampin is the cause of AKIs in TB patients. Very important. So I have to monitor for the kidney function as well. Liver function tests for all these drugs patients must be done. Usually you start usually you can start as early as weekly or even basically 3 times a week. First, in the first phase of TB therapy, you start, of course, monitoring liver function test, kidney functions. You monitor, of course, them 3 times a week. Later on, of course, you do weekly. After about a month, you can do weekly, and then of course after that patient becomes stable, you can do monthly. But monitoring is very important because some people may have what you call hepatitis, which might occur even within after a few dosages of the drugs, or even, of course, during therapy, or even at the end of therapy, patient may have liver dysfunction from this medication. All right. Then I've got Pyrazinamide PZ, of course, which is the Mide PZ, is a very good drug. The worry about this drug, guys, that this drug is actually can exacerbate gout. So it's known to increase, of course, uric levels, and of course, so distribution in the joints. So it can cause joint pains. This drug can cause that. So rare new onset gout is rare due to pyrazinamide, but can precipitate gout. Though that's what about this drug. Apart from that, it is the most toxic drug. It's the most hepatotoxic drug. Pyrazinamide is the most hepatotoxic drug among the drugs that are here. We are seeing here. This is the most hepatotoxic drug. This this very important, all right? And the last part is Ethambutol. Ethambutol is a very important drug in this category, and the reason I like the fact that Ethambutol, it acts as a resistant barrier. Somebody may ask, how come? How does it act like that? The way Ethambutol works, you know that TB mycobacterium has got a very amazing layer. The first layer, of course, is what you call the mycolic acid layer, and I've got other layers following there. We've got what you call even the peptidoglycan layer is also part of the TB buster itself. We've got other inner layers like also the arabinogalactam layer itself. That layer, arabinogalactam layer, it's a layer that emits special proteins which act as anti-phagocytic. All right, means evading your immune system or simply preventing your immune system from killing the organism. And if organism, of course, is being killed, if it's not being killed, it's multiplying at a very fast rate. As a result, fast multiplication can easily result to mutation, which can bring about resistance to this mycobacterium. So rifampicin works by simply inhibiting an important enzyme known as what you call the arabinotransferase enzyme. This enzyme is important in the biosynthesis of this same arabinogalactam layer. That's how it will act as a resistant barrier. So this drug, of course, is very important to be added in the induction phase. We stop it, of course, at 2 months. Why? Because by that time, as long as the patient, we have obtained a sterile sputum, of course, or a pulmonary system in the patient, there we are confident that the resistant development, of course, chances are very low and minimal. So as a result, this drug can go. PZ is a drug that works very best in an acidic environment. So that's why after 2 months, of course, of active phase disease, while there's a great inflammation, you have to be more acidity. This, of course, also precipitates or increases the activity of pyrazinamide. But after that active disease, of course, has been warded off, you find that TB activity becomes reduced. It's reduced, of course. That's why you can discontinue that later on, of course, after having obtained the sterile samples, and then wait for 2 months, then de-escalate to these 2 medications that are there. This is regard to how you treat tuberculosis, basically, guys. And these are the drugs that we use, of course, in the drugs of tuberculosis that I've highlighted here today. So this is what I had for today. Just and for more videos, and I'll highlight further topics next time, talk about the detailed part of how pharmacological of the drugs later on. This is what I had, and enjoy the first season. See you again next time.